There was supposed to be a presentation before the case. I suggest we switch it because the case is ready, so we first...
Absolutely. It was my, let's say, proposition to start with the case in order not the patient to wait on the table. Okay. And finally, Dr. Stoyanov will tell several words about the technology, ICD technology. Of
Shall we show a short presentation of the case? Dr. Ivanov, I think, is ready.
Next case is 53 years old female patient, 2 days after onset of severe headache, of vomiting, Hunt and Hess 1st degree, Fisher 3rd degree. Aneurysm, subarachnoid hemorrhage. This is the control result 1 year after coiling. But on the 3rd year, we have recanalization. We took a decision to put a flow diverter in the right internal carotid artery, and Dr. Alioski is next.
Hello. Hello, Iris.
Hello, we hear you. Now we can see you as well.
Till now, we have a 6-range distal access approach with React 071 on the siphon on the right carotid artery, and after that we are with Phenom 27 in the middle cerebral artery. You can see the top of the microcatheter. Here is the top of microcatheter. For this aneurysm, we choose to use pipeline 425 to 20 shield technology, and now we will put the folder. Okay, ready. I put the top of microcatheter on the MCA because he is a little bit tortuous, and to have a good stability of the microcatheter, he is up on MCA aneurysm. Yeah, correct? Your hand. Okay. We're going up. Here is the stent. Okay. It's a little bit longer. Okay, now everything is straight, and we can start a little bit. I will resheet it. Okay.
Nuri, could you tell us about the materials and the implants that you are using?
It's a pipeline shield technology. This means that he has an antiplatelet characteristic of the stent. Yes. I think that it's the position is okay. It's below the A01 and before the bifurcation, actually.
Do you have a biplane machine or?
Oh, it's monoplane. I think that only advantage of biplane is when you treat the AVMs. It's a little bit longer, but
As you mentioned, it's a massage.
yes, yes.
Push pull, push pull, push pull.
Yes, on the curve
As always,
of the vessel
all lifelong push pull.
to have a. Yes, it's fully open. I will open it now. I will restore. Yes. Okay.
In fact, it's helpful for the apposition of the stent, especially for flow diverters. It's extremely important to facilitate, in fact, to stimulate the apposition. So this is very important, and especially in brain vasculature that is so tortuous, this maneuver is very, very important. Absolutely. Hopefully, Iris, you will agree with me. It's not so simple like a coronary stent push and inflate in 10 seconds. No, there is nothing to do. It's much, much more special.
Now, I will wait for the venous phase to see the stagnation of the contrast in the aneurysm.
Yeah, good demonstration.
I go out. Okay. The visibility of the stent, it's okay. Final control angio. And we are ready for questions. Okay. Okay. Now we see the position of the stent. Perfect.
And we can
Okay.
also see the flow of S. We can also see that there's already some stasis and the stagnation of contrast inside.
Yes.
In this context, as an ignorant cardiologist, I wanted to ask you regarding the antiplatelet treatment. We have two controversial targets: to keep patency of the stent, of the flow diverter, and to have thrombosis of the aneurysm. What is the regimen of antiplatelet in this situation?
Because it's matter of brain, of course, that we have, we want to see patency in the parent vessel.
Okay, so what is the regimen? What would be?
Double antiplatelet therapy.
Yeah. For how long?
For 6 months, double antiplatelet, and monotherapy for 1 year.
Okay, just a question: is it written into the guideline or it's your practice?
In most of the centers, they work with double antiplatelet.
Okay, it's well to know.
Now the couple of centers they suggest 3 months. It depends about the center, and I don't know, Miro, in your center.
We still stick to 6 months dual antiplatelet and 1 year for mono. We leave it just for the aspirin. But after we starting to put this new coating of the Phenux stains, It's the hydrophilic coating. We have several patients on monotherapy from the beginning. We stick to them only with prasugrel, 10 milligrams per day. The one lady was allergic to aspirin, and the second one I have a history of very severe stomach bleeding. So we decided to put these two patients. We already have first control for the 6 months, nothing special, no strokes. So again, we didn't observe any hyperplasia, in-stone stenosis hyperplasia or something like that. So maybe this coating of the stents, like you mentioned, shield technology, could be potentially changing the guidelines in the future, and we stick to the monotherapy with these stents.
And also with Cangrelor, for example, with Cangrelor, which is also IV and has been used for single antiplatelet therapy.
If we needed to put it in emergency case, if it's
in
a
the
rupture
acutely
aneurysm,
bleed, exactly in the ruptured aneurysm, it is
blister one,
an
we
option.
can do it. It's still so
quite expensive, yeah,
in Bulgaria. But
and you have to give a continuous infusion as well. But the main thing is the price.
At least for 24 hours, and you can switch to Ticagrelor or Prasugrel.
Yeah. Which would also go back to when you were previously asking about antiplatelets. So the good thing is you can give it IV. I think it's the only one available in IV version.
Yeah.
Price is a problem, continuous infusion is a problem, but it may be something for acutely ruptured aneurysm where you need single antiplatelet therapy.
Unfortunately, I don't believe it's available in Bulgaria. I don't know,
is.
but it is?
You can buy it by yourself or your hospital.
But it's slightly expensive, yeah.
It's like around 400 euro per vial, and this vial is enough for one hour and a half.
Mm-hmm.
If you want to cover 24 hours until we switch to Ticagrelor, it's quite expensive.
Mm-hmm.
The thing is, it has a very fast switch on and switch off, so it basically immediately works, but the good thing is if there is bleeding, it will immediately be out. So from a drug point of view, it's really ideal. From a price, it's prohibitively expensive.
For example, if your neurosurgeon needs to put a drainage, extraventricular drainage, you can switch the Cangrelor and they can do it in 3 minutes. In 3 minutes, there is no inhibition for the...
I'm curious regarding proliferation. How often do you see proliferation in a stent diverter?
In the old versions of the flow diversion, without coating, just the standard flow diversion, we have like less than 5% observation, the 6 months control, and if we stick and do another run follow-up in 1 year, after that only on the aspirin, it's completely gone.
And what if you have critical stenosis within the flow diverter?
I, in my experience, never saw it until this moment.
Yeah.
I have one significant hyperplasia, and we just consulted. Should I do something? Should I put a balloon, dracheliotic balloon or something? They told me, don't touch it. And in 1 year, it was completely resolved.
This is interesting.
Just aspirin, no sticking to dual antiplatelet. In their experience, they saw a lot of these cases. I'm not sure are they publish it with long follow-ups, but only on a single therapy in 1 year, it just disappeared.
Great.
Can I ask one more question to the operator? Your experience with intraluminal flow diverters, like the web or flow diverters directly within the aneurysm, does that play a big role? Do you go for conventional coiling with stent assistance and flow diverter, or what is your practice using flow diverters within the aneurysm? Like
I
the
don't
web?
have a lot of experience with web, with intrasaccular device. In regular, we do stent-assisted coiling, balloon-assisted coiling, or flow diverter. I mentioned that we are neurosurgeons, and for the complex type of aneurysm, we do surgery.
Thank you.
I will comment about the stent stenosis. In regular, I put the patient for a couple of months with statins, and I think that it's okay. The patient who is older than, for example, 55 years, to put him on statin, with statin at home.
I see.
And important part, it takes about 9 to 12 weeks for the stent to be covered again with a new endothelial layer, which means that for a minimum of 3 months, one has to give the dual antiplatelet, but it still varies a bit amongst patients, so going longer is a good option. Main challenge that we often see is with patients going to their doctor or the dentist, and they say, no, we're going to pull our teeth, take it out. So it's a big education part for the patient or family that they cannot stop their dual antiplatelet. Do you do testing of these patients for responders and non-responders?
Yes, in our department, one of our colleagues just gathering a big number.
Yes.
Because at the beginning we are sticking with clopidogrel and aspirin, so we started to test with Verify now.
Yes.
The clopidogrel patients, and there is one proposition from the Turkish group of Professor Çekirge that after the original medicine, the Plavix,
yes,
I think, the clopidogrel start to be not so stable in the different shape.
Yes.
That's his proposal, and maybe we saw the same. After 2015-16, we saw like maybe 15 to 20% resistance to clopidogrel in our group. So we switched these patients to prasugrel, and we have more than 150 patients already with prasugrel with no resistance catch with Verify now until now. So we already switched to prasugrel completely. We didn't start with clopidogrel, test the patient, and switch to prasugrel. And we don't have ticagrelol groups in.
Okay.
We prefer to be one dosage per day medicine because I think it's more easier for the most patients.
Perfect.
So we test.
Klaus, how do you do it? Do you recommend testing for resistance or no resistance?
For clopidogrel, otherwise you have no effect. Yes.
Yes.
The patient is flicking some drugs and without any effect.
And
so
it's actually 30%.
Yes, it's not 1 per mil, but it's really a percentage, a considerable percentage. Yes. But I also want to add perhaps to the aneurysm coiling. I expect that not all of you are doing these procedures. Yes. So when you have a very narrow egg, you can coil very easily and fill it very good. When you have a large neck, the coils have a good chance to drop out. And then you have also different techniques, which were shortly mentioned. You go with 2 microcatheters, so you have one with a balloon and you block it, but first you have to go in with your microcatheter into the aneurysm sac, and then while it's blocked, you can fill it, but when you have a very large opening, a large neck of the aneurysm, still you have a chance when you deflate the balloon that some of the coils will have contact and protrude into the lumen of the artery. And when you work with flow diverter or stent, yes, you have also 2 options. You first place the stent and go through the meshes and coil, or you go with 2, place the tip of your coiling microcatheter in the aneurysm sac. Then with the second system, you place a stent, and then you can coil, and at the end, you pull out the microcatheter. So there's different options how to do that. Yes, depending on the size, on the shape of the aneurysm, and the size of the neck. Yes.
Professor Mathias, Dr. Sirakov is going to present just that in the next session.
Oh, yes.
The all availability for wide neck aneurysms. And you know, this is very fast developing area in which we have a lot of devices, and we are very lucky that in Bulgaria we can also develop first-in-human devices, or to be pioneers in some of them. So I think you're going to see something interesting, like if you're familiar with the Comaneci device, Cascade, and the latest one is Nautilus, which could be an opponent of the web. Do you familiar with the Nautilus? You'll see later.
I only wanted to mention it for the audience because the CEO has to play something. But you are right, we will have more detailed information is coming.
Yes.
I'm sorry, but for the purpose of time, we have to move on. We have one more presentation from Dr. Stoyanov, who will talk about stroke prevention.
Thank you, Dr. Alioski.
Thank you. Thank you very much for the great case.
See you soon.
Dear chairs, dear colleagues, thank you very much for the opportunity to talk today in front of you. I'll change a bit the topic, and my talk is going to be about the cryptogenic stroke prevention and long-term monitoring of the cardiac rhythm. As we all know, the atrial fibrillation is a really common condition, and it affects around 1 to 2% of whole population worldwide. The atrial fibrillation is associated with 5 times increasing of the risk for ischemic stroke. And when we have the both condition, that atrial fibrillation related, stroke related to the atrial fibrillation, we have nearly twice more likely to have a fatal stroke compared to the patient with stroke not related to atrial fibrillation. As you can see on the slide, that's the TOAST classification of the stroke, and it's underlined that according to this classification, we have around 20% cardioembolic strokes. That means that it's really important to know how to prevent such a strokes. And the most important here is to say that we have around in between 25 to 40% cryptogenic stroke. That means that we don't know what's the cause of the stroke. And what's the problem with the cryptogenic stroke? Sometimes we don't know how to find the reason for stroke, and we have incomplete diagnostic. Sometimes the cause is not persistent. We have for example, paroxysmal atrial fibrillation, or we have 2 or more causes for the stroke. About the cardioembolic stroke, it's really severe, and why? Because we have about 50% morbidity and invalidity, and in terms of the mortality rate, it's about 25% at the day 30, and around 1.5 of the patient died the first year, and this is incredible number. Really often, about 20% of our patients, they have a first manifestation of the atrial fibrillation as a stroke. And we have a lot of patients completely asymptomatic with the atrial fibrillation. This is really important to be known. How we should detect the atrial fibrillation? We have a recommendation from our European Society of Cardiology, and to say yes, we have atrial fibrillation, this diagnosis required ECG documentation, and this is mandatory. How we have several tools to detect the atrial fibrillation, and according to our recent guidelines to 2020 of European Society of Cardiology, we have several steps to detect atrial fibrillation. We can use this rule of 15 seconds palpation of the pulse for our patient. They can do this at home or during our office visit. Or the second step is to have a 12-lead ECG when they feel arrhythmia. After that, we have another tool. It's Holter monitoring, and we can have a 24 hours Holter monitoring, and we also can extend until 1 week this monitoring. But is this enough? Let's say no. We have another 2 tools which we can use. The first one is external loop recorder, but we can use this continuous recording until 30 days. And the other more powerful and really useful tool is the loop recorder. We can implant this really small device, and we can have continuous monitoring, really stable, with a lot of information until 36 months. Nowadays, we have a lot of new devices, smart watches, and different smart devices, and they provide useful information about our rhythm. We have several trials about this, and probably this is a promising future. Is 30 days enough to find our patient with atrial fibrillation and the reason for the cryptogenic stroke? The answer is short, no, because we have huge data about this, and at the day 30 of the cardiac monitoring, in the real-world diagnostic, we have only 5% of patients that are, we detect only 5% of the atrial fibrillation in a cryptogenic stroke patient. What to do? How to improve the treatment of our patients and to find the reason for their cryptogenic stroke, because it's really often condition. We can use these small devices. They're really, really small, and it's not a huge surgery. It's a small device that should be implanted next to the sternum and in a proper position. And we have really a lot of advantages when we use this promising technology. And we improve our diagnostic process, and we found our patient and atrial fibrillation and also other conditions, but the topic today is cryptogenic stroke. We have continuously monitoring of the patient. We have a stable ECG during the symptoms, and the patient, also in the patient that are asymptomatic. What about the patient, how they feel this technology? Because it's a small surgery, they're probably not comfortable with this and they refuse such technology. No, we have a small trial from BEC, and this on the slide you can see that the patients are really satisfied with this technology compared to the patients with external whoop recorders. You can see 21% versus 10%, and this is really important to be known. I want to show you this incredible good study. It's called the Crystal AF study. It's really well-designed study, and with clear cryptogenic stroke patients. They have brain infarct seen on MRI or CT, and this is documented within the previous 90 days. And the reason for the stroke is completely unknown. They have before inclusion 12-lead ECG, and also Holter monitoring, transesophageal echocardiography to detect PFO or ASD on the intraarterial septum, and the patients are over the 40 years. The follow-up is 3 years. And what's this study review? The authors found that implanted patient, the active group patient, compared to control group, they have 7 times more detected atrial fibrillation. And in this group, the patients received proper therapy, and in 97% they received the oral anticoagulation. And this is really important. And they conclude that the more you look, the more atrial fibrillation you find. What's the value of the Whoop recorders? This is a continuous monitoring and for the cryptogenic stroke patient, and this tool is superior to standard care according to Crystal AF trial. And 30 days, because a lot of people are using external loop recorders, 30 days are not enough. And they're well recommended, and in our guidelines, this is on the slide is part of the guidelines 2020, the European Society of Cardiology, and recommendation. They are really well recommended in the patient with the cryptogenic stroke. We also have this paper from the European Heart Rhythm Society and the other society from Asia Pacific and Latin America. And you can see on the left part of the screen these green hearts. This is the same recommendation as level 1A from the European Society of Cardiology, and they suggest that the use of implantable loop recorders should be considered for detection of atrial fibrillation in selected high-risk patient. And also they called these implantable loop recorders the right tool for the right outcomes. But at the end, it's written also in the right population. You should keep in mind this. My take-home messages are that implantable loop recorders are the best tool for diagnose silent atrial fibrillation in patients with previous cryptogenic stroke. And you should keep in mind and to send the patient, if you have such a patient, to receive such a technology, because it's really important, and they should receive a proper medication, because as you know, the antiplatelet with the clopidogrel or aspirin, it's not enough, and it's not really good in a patient with atrial fibrillation and stroke. Thank you for your attention.
Yeah, thank you very much for that information and your presentation. One question: when do you do also ultrasound examinations?
Yep.
To see what is going on in the atrium? You do that routinely also, yes, when you detect atrial fibrillation or not?
You mean when we perform an echocardiogram?
Yes, echocardiogram, because you want to see when you have a patient with atrial fibrillation, naturally yes. The next question is there already something in the atrium forming thrombus and so on?
Thank you for your question. With the transthoracic echocardiography, the right atrium and the appendage of right atrium is not really well seen. We should perform transesophageal echocardiography or CT to detect if we have such a problem. But my topic was for the cryptogenic strokes, yes. And we really don't know the cause for the reason for the stroke in such a patient. And I really believe that this technology will change the world practice and will save us the lives.
Okay.
What do you think will be the impact when now more patients are on NOACs, DOACs, on the thrombolysis rate? So on the patient, because reversal, difficult, so if now patients do come and they've had an event, the thrombolysis rate, of course, will be impacted. So probably that, again, will push the amount of thrombectomy rates.
Yes.
And the thrombolysis rate may go down. So yes. Although we're preventing strokes, if there is no way to deal with these patients in a different way, because your hands are bound if you want to give thrombolysis, except if we now have reversal. if we look at reversal.
Thank you.
So what I'm saying is we have to look at both
misunderstand the
sides. Yes,
question.
you are preventing them. You are preventing strokes on the
Yeah.
one hand, but those who do get a stroke despite being on them, your hands are tied when they come for the thrombolysis, so you need to have another safety mechanism, which may already be the
thrombectomy.
thrombectomy.
It's the best way to
Or
to do
reversal,
this, yeah.
or we have, yeah, okay.
Yeah, thank you.
Yeah, so then we close that session because we have talked about the stroke programs, different versions and what you have to organize and so on. And now we continue with neurovascular interventions. So it's not only stroke, we have also other diseases at the brain arteries.
Thank you. Second session.
I will